Welcome to Bookfulness. This is episode 38. We're carrying on with our deep dive into clinically oriented anatomy, really looking at how the body, maps itself out structurally.
Yeah, last time we really laid the groundwork, didn't we?
Ah,
The bones of the neck, cervical vertebrae, hyoid, and that crucial deep cervical fascia, how it all fits together.
exactly, how it compartmentalizes everything, which, as you said, is vital for knowing where things should be and where infections might get trapped.
Or where they might spread, which is often the bigger clinical concern, right, based on those fascial planes.
Right. So today the plan is to build on that foundation. We'll look more superficially first at the regions, the big defining muscles.
Mm-hmm. Sounds good. Then we should probably dive down into the root of the neck, that really busy intersection of nerves and vessels passing between the thorax and the head and arm.
Yeah, the neurovascular highway, as you
Yeah.
called it. And then connect it all up to the head, look at the skull structure, the face, and some really key clinical points there too.
Absolutely, all ties together. The neck doesn't exist in isolation, obviously.
Yeah.
So looking at the head and face structures makes perfect sense.
Okay, great. Let's get into it then. Hashtag tag BB, the structural organization and superficial regions of the neck. Okay, so let's start back with those deep cervical fascia layers we touched on last time. We mentioned the investing layer, the pretracheal, and the prevertebral. Now, clinically speaking, these aren't just abstract sheets of tissue, are they? They're fundamental to understanding pathology.
Oh, absolutely fundamental. Think of them as like internal firewalls or barriers.
Yeah.
How they attach and the spaces they create between them dictates exactly where things like, well, infections can and cannot go.
So could you walk us through an example, say an infection between the investing fascia, that outermost one, and the muscular part of the pretracheal fascia?
Right. So the investing fascia, remember, wraps around everything, kind of like a collar. And importantly, it attaches quite firmly down onto the manubrium, the top part of the sternum. So if you get pus or fluid collecting between that investing layer and the muscular part of the pretracheal fascia, which is just deep to the infraoid strap muscles,
Yeah.
well, that attachment to the sternum acts as a barrier.
Ah, so it effectively walls it off inferiorly. The infection might cause pressure, maybe bulge outwards, but it generally doesn't track down into the chest.
Exactly. It tends to stay confined to the neck, usually not spreading below the superior edge of that manubrium. It's relatively contained.
Okay, relatively contained. Now, contrast that with what if the infection gets into a different space, say between the investing fascia and the visceral part of the pretracheal fascia?
Ah, no, that's a different story, a much more serious one. The visceral part of the pretracheal fascia is the layer that directly encloses the thyroid gland, the trachea, the esophagus, the neck viscera.
Okay.
And here's the critical point. This visceral layer doesn't stop at the sternum. It continues downwards, becoming continuous with the fibrous pericardium surrounding the heart and the connective tissue around the great vessels in the chest.
Wow. So there's no barrier there. It's
Right.
it's an open pathway downwards.
Precisely. It's like a superhighway for infection. If pus gets into that space, it can track directly, with nothing stopping it, right down into the anterior mediastinum. That's the space in the chest, just in front of the heart.
And that leads to mediastinitis,
Yeah.
which is incredibly dangerous.
Extremely dangerous, often fatal if not treated aggressively. So you can see how understanding which fascial compartment is involved is absolutely critical for prognosis and treatment. It's pure anatomy dictating clinical urgency.
That's a stark contrast based on just which side of a fascial layer you're on. Now, what about posteriorly? You mentioned the prevertebral layer last time. There's a space associated with that too, right? The retropharyngeal space.
Yes, the retropharyngeal space. And it often gets called the danger space of the neck, for good reason. It lies immediately behind the pharynx and esophagus, but in front of the prevertebral fascia, which covers the vertebrae and the deep neck muscles.
Okay, so behind the throat, in front of the spine, basically?
Basically, yes. Now, imagine an infection starting deep, maybe from a vertebra itself, like tuberculous spondylitis or deep trauma. If that abscess builds up behind the prevertebral fascia,
It could push forward.
it can actually perforate or erode through that prevertebral layer and spill into the retropharyngeal space.
And once it's in that space,
Well, now it's directly behind the pharynx. The accumulating pus causes the posterior pharyngeal wall to bulge forward. Clinically, this presents pretty clearly.
how so? What would you see?
The patient would have significant difficulty swallowing. That's dysphagia because the bulge is physically obstructing the path of food. They might also have difficulty speaking clearly dysarthry for the same reason. You'd see this bulge on examination.
But the danger isn't just local obstruction, is it? Where can it go from there?
That's the real danger part. The retropharyngeal space isn't closed off inferiorly either. It communicates directly downward with the superior and posterior parts of the mediastinum.
So, again, a pathway straight into the chest.
A direct route. Infections originating even higher up, maybe in the head or tonsils, can potentially track down this space, running behind the esophagus, or even shifting anteriorly to run behind the trachea, reaching the vital structures around the heart and lungs. It truly is a danger space defined by these fascial continuities.
Incredible how these layers channel everything. Okay, so that covers the deep organization and its clinical importance. Let's move more superficially now. When we're trying to map out the neck, say for an exam or planning surgery, what are the main muscular landmarks we use?
The two big ones, the real defining muscles, are the sternocleidomastoid, usually just called the SCM, and the trapezius. These large muscles, which are themselves enclosed by that outermost investing layer of fascia, effectively divide the neck into its major regions.
Right, you get the anterior triangle, the posterior triangle, the SCM region itself.
Exactly. They form the key boundaries for navigating the neck's contents.
Let's focus on the SCM for a moment. It's such a prominent muscle. Tell us about its attachments and, maybe more interestingly, its actions. It seems to do quite a bit.
It really does. So superiorly, it has a broad attachment to the mastoid process, that bony lump behind your ear, and also onto the superior neutral line of the occipital bone.
Okay.
Inferiorly, it splits into two heads. There's a rounded, tendinous sternal head that attaches to the manubrium of the sternum, and a thicker, fleshy clavicular head that attaches to the medial third or so of the clavicle, the collarbone.
Two heads inferiorly, one broad attachment superiorly, and its actions.
This is where it gets interesting because it depends on whether one side contracts or both. If you contract just one SCM, say the left one, it does two things simultaneously. It tilts the head towards that same side, so left lateral flexion, but it also rotates the head so that the face turns upwards and towards the opposite side. So left SCM contraction makes you look up and to the right.
Huh. That's quite a complex movement from one muscle, tilting towards rotating away.
It is. It allows for that sort of head cocking and looking away motion.
And if both SCMs contract together?
Acting together, their main action is actually to extend the neck at the very top joints, the atlanto-occipital joints, where the skull meets the spine. They pull the head backwards. They can also help with flexing the lower cervical spine, pulling the chin towards the chest, especially if you're overcoming resistance.
Clinically, how do we test the SCM? And why is it important?
Testing is straightforward. You just ask the patient to turn their head to one side against the resistance of your hand placed on their chin or cheek. You'll see and feel the contralateral SCM contract strongly.
Okay.
Its importance comes into play in conditions like torticollis or wry neck, especially congenital torticollis, where the muscle might be shortened or fibrosed from birth injury. This results in that characteristic fixed head posture, tilted to one side, rotated to the other, perfectly demonstrating the muscle's normal action, just pathologically fixed. It shows how crucial SCM balance is for head posture.
Right. Before we use the SCM to define regions, there's one other superficial muscle we should probably mention, the platysma. It's almost like part of the face, isn't it?
It really is. The platysma is this incredibly thin, broad sheet of muscle that lies right within the subcutaneous tissue, the superficial fascia of the neck. It's not contained within the deep investing fascia like the SCM or trapezius.
And its innervation is different too.
Yes, it's innervated by the cervical branch of the facial nerve, cranial nerve is the seventh, which tells you about its developmental origin with the muscles of facial expression.
Where does it run from and to?
It actually originates quite low down, from the fascia covering the upper parts of the pectoralis major and deltoid muscles, over the shoulder and upper chest. Then it sweeps upwards, immediately across the clavicle and up the neck.
And inserts where?
It blends into the inferior border of the mandible, the lower jawbone, and also into the skin and subcutaneous tissues of the lower face and corner of the mouth.
So what does it actually do? Its action seems quite subtle.
It is subtle. Its main actions are to help depress the mandible, so slightly open the mouth, and perhaps more noticeably, it draws the corners of the mouth downwards and outwards. This creates those expressions we associate with, say, sadness or maybe fright or tension, like when you grimace.
Okay. Pulling the mouth corners down.
Right. It also tenses the skin of the neck. If you clench your teeth really hard, you can often see the platysma stand out as vertical ridges in the neck, pulling the skin upward slightly.
Why is this very superficial muscle clinically relevant then?
Mainly for surgeons, Because it's so superficial, it's often the very first muscle layer encountered and incised during surgical approaches to the anterior neck, like for thyroid surgery or carotid artery procedures.
So you have to cut through it.
You do, and the key thing is that the cervical branch of the facial nerve, which supplies it, often runs just deep to it or within its deeper fibers. So careful dissection is needed to identify and preserve that nerve branch to avoid weakness around the lower lip postoperatively.
Right, preserving function. And I guess managing it during closure is important for cosmetic outcomes too, minimizing scarring.
Exactly. Because it tenses the skin, how you handle and repair the platysmal layer can influence the final appearance of the scar.
Okay, so using the SCM and the trapezius now as our main landmarks, let's define that lateral cervical region. It's often called the posterior triangle, right?
That's the classical name, yes. The posterior triangle or lateral cervical region. Its boundaries are very clearly defined by those two muscles plus the clavicle.
So what are the borders?
The anterior border is the posterior edge of the sternocleidomastoid muscle. The posterior border is the anterior edge of the trapezius muscle. And the inferior border, or the base of the triangle, is the middle third of the clavicle. The apex is where the SCM and trapezius meet superiorly on the occipital bone.
Okay, SCM, trapezius, clavicle. And what forms the floor of this triangle? What lies deep to the space?
The floor isn't just one flat thing. It's actually formed by several muscles that are covered by the prevertebral layer of deep cervical fascia. So, moving from superior to inferior, you typically find the splenius capitis, the levator scapulae, and then the posterior and middle scalene muscles. The interior scalene is usually just deep to the SCM border.
So a muscular floor covered by that deep prevertebral fascia. This triangle isn't empty, obviously. It's a major conduit. What's one of the most clinically significant nerves running through here, and why is its location a bit precarious?
The big one here, clinically speaking, is the spinal accessory nerve, cranial nerve ischium.
CNAOA. What makes it so important and vulnerable here?
It's critical because it provides the sole motor innervation to both the sternocleidomastoid and the trapezius muscles. Its vulnerability comes from its course. It runs relatively superficially across the posterior triangle. In fact, it's often described as the only major motor nerve that lies superficial to the prevertebral fascia in this region.
Ah, so it's not protected by that deep fascial layer as it crosses the triangle?
Not as it crosses the floor muscles, no. It's running just deep to the investing fascia and subcutaneous tissue. This makes it particularly susceptible to injury during surgical procedures in this area, like lymph node biopsies or radical neck dissections for cancer. Iatrogenic injury caused by medical treatment is unfortunately not uncommon.
And the consequences of injuring CNXI?
Significant shoulder dysfunction. Paralysis of the trapezius leads to drooping of the shoulder, inability to elevate or shrug the shoulder effectively, and often chronic pain and winging of the scapula. Paralysis of the SCM adds weakness in turning the head against resistance.
Can you trace its specific path through the triangle? Where does it enter and exit?
Sure. It typically emerges from beneath the posterior border of the SCM, about 1/3 of the way down from the mastoid process, a point sometimes called Erb's point, although that term is more associated with the sensory nerves.
Okay, upper part of the SCM's posterior border.
Right. From there, it runs diagonally downwards and backwards, or postero-inferiorly, across the surface of the levator scapulae muscle, which forms part of the floor, heading towards the anterior border of the trapezius. It then disappears deep to the trapezius, usually about 2/3 of the way down its anterior border, innervating it from its deep surface.
That relatively superficial course across the triangle really highlights its vulnerability. Now, you mentioned Erb's point, or near there. That area is also significant for nerve blocks, isn't it? The cervical plexus block.
Yes, exactly. The superficial sensory branches of the cervical plexus from spinal nerve C1, C4 also emerge from behind the posterior border of the SCM, around its midpoint. This collection of nerves fans out to supply the skin of the neck, the back of the scalp, and the area over the shoulder.
So you can block sensation in that whole area with one injection.
Pretty much. By injecting local anesthetic near this nerve point of the neck, along the posterior border of the SCM, you can achieve widespread cutaneous anesthesia for superficial procedures on the neck or shoulder region without needing general anesthesia.
Sounds useful. But is there a risk? You often hear about potential complications with neck blocks.
There is a significant potential risk, and it relates back to the deeper structures. The phrenic nerve, which arises from spinal roots C3, C4, and C5, runs vertically downwards deep in the neck, specifically on the anterior surface of the anterior scalene muscle, which lies just deep to the SCM border where the block is performed.
Ah, so the anesthetic could spread inwards and reach the phrenic nerve.
Precisely. The phrenic nerve is critically important because it is the sole motor supply to its respective hemidiaphragm, half of the diaphragm muscle essential for breathing.
Sole motor supply. That sounds crucial.
It is. If the anesthetic agent inadvertently blocks the phrenic nerve, it causes paralysis of that half of the diaphragm.
What does that mean for the patient?
Well, in a young, healthy individual with good lung function, losing the function of one hemidiaphragm is usually tolerated okay. Breathing becomes a bit more effortful, but they manage. However, in a patient who already has compromised respiratory function, maybe severe COPD or other lung diseases, suddenly losing half of their main breathing muscle can be catastrophic. It can lead to respiratory distress or failure.
So it's a calculated risk, the convenience of a regional block versus the potential for significant respiratory compromise, especially in susceptible patients.
Exactly. You have to weigh the benefits and risks carefully and be very precise with the injection technique to minimize spread to the phrenic nerve. It really underscores how tightly packed and functionally critical the structures in the neck are.
Okay, that brings us nicely down to what you call the highway, the root of the neck. This sounds like a really critical junctional zone. How do we define this area anatomically?
The root of the neck is essentially the transition zone between the neck proper and the thorax, or chest cavity. It's the area immediately superior to the superior thoracic aperture.
And the superior thoracic aperture is that bony ring at the top of the rib cage.
That's right. It's formed by the first pair of ribs laterally, the manubrium of the sternum anteriorly, and the body of the first thoracic vertebra, T1, posteriorly. It's a relatively small, rigid opening.
So the root of the neck is the tissue-filled space just above that opening. Must be pretty crowded in there.
Extremely crowded. Everything passing between the head, neck, upper limbs, and the torso has to funnel through this narrow gateway. Major arteries, veins, nerves, lymphatics, the trachea, the esophagus, they're all packed in here.
Let's try to untangle some of that traffic, starting with the arteries. The subclavian artery is the major player here, arching over the first rib. What are some of its key branches that arise in the root of the neck?
Okay, the subclavian artery is divided into three parts, relative to the anterior scalene muscle which crosses over it. Several important branches arise, particularly from the first part, medial to the muscle. The most significant trunk arising here is usually the thyrocervical trunk.
Thyrocervical trunk? Sounds like it supplies the thyroid.
It does, via one of its branches. The thyrocervical trunk is typically quite short and thick, and it quickly divides into usually four branches.
Okay, what are they? And which one is the real star player, clinically speaking?
The star player, without a doubt, is the inferior thyroid artery.
Why is that one so important?
Because, as its name suggests, it's a primary blood supply to the thyroid gland and also the parathyroid glands which lie behind it. But it goes beyond that. It's often considered the main visceral artery of the neck. It also supplies the larynx, trachea, esophagus, and surrounding muscles.
Wow, okay, so crucial for many structures.
Absolutely. And its relationship with the recurrent laryngeal nerve, which controls most of the larynx muscles, is incredibly important surgically. Damaging either the artery or the nerve during thyroid surgery has serious consequences. They run very close together.
Got it. Inferior thyroid artery, key visceral supply. What are the other three branches off the thyrocervical trunk?
Usually you have the suprascapular artery, which runs laterally across the neck, eventually heading back towards the scapula to supply muscles around the shoulder blade. Then there's the superficial cervical artery, sometimes called the transverse cervical artery, which also runs laterally across the posterior triangle, supplying muscles like the trapezius. And finally, there's often a smaller ascending cervical artery that runs upwards on the deep neck muscles supplying them.
Okay, so branches mainly for the thyroid viscera, the shoulder region, and local muscles. Is there another major arterial trunk coming off the subclavian in this area?
Yes, typically arising from the second part of the subclavian, posterior to the anterior scalene muscle, is the costocervical trunk.
Costocervical, ribs and neck.
Exactly. It usually passes backwards and superiorly before dividing into two main branches. One is the supreme intercostal artery, sometimes called the superior intercostal artery.
And that supplies.
It descends behind the pleura, the lining of the lung, to supply the first and sometimes the second posterior intercostal spaces, the spaces between the upper ribs at the back.
Okay, providing blood supply high up in the chest wall. And the other branch of the costocervical trunk.
That's the deep cervical artery. This one ascends in the back of the neck, running deep between muscles like the semispinalis capitis and cervicis, supplying these deep posterior neck muscles. So the costa cervical trunk handles some high thoracic wall supply and deep posterior neck circulation.
Right. Lots of vital plumbing packed in there. Now let's switch to the nerves passing through this highway. We have some major cranial nerves and spinal nerves here. Let's start with the vagus nerves, cranial nerve X. We know they come down from the head. How do they navigate the neck and its root?
The vagus nerves are really important players here, carrying parasympathetic innervation down to the chest and abdomen. As they descend through the neck, they travel within the carotid sheath.
That fibrous tube containing the carotid artery and internal jugular vein?
Exactly. The vagus nerve typically lies posteriorly within that sheath, nestled between the common carotid artery, or internal carotid higher up, and the internal jugular vein, IJV. It maintains this protected position for most of its cervical course.
Okay. And as it reaches the root of the neck, preparing to enter the thorax, does its path change?
It does, and importantly, the path becomes asymmetric between the right and left sides. This is a key anatomical difference.
How so? Let's take the right vagus first.
The right vagus nerve, as it reaches the root of the neck, tends to pass anterior to the first part of the subclavian artery. It then angles posteriorly and medially to run down towards the trachea and esophagus.
Okay. Anterior to the right subclavian artery. And the left vagus.
The left vagus nerve descends a bit further down into the root of the neck before entering the thorax. Its path takes it between the left common carotid artery and the left subclavian artery, just as the subclavian arches over the lung apex. It then passes posterior to the root of the lung.
So different relationships to the major arteries on each side. Right vagus anterior to subclavian, left vagus between common carotid and subclavian. That sounds important for surgeons working near the thoracic inlet.
Very important. Knowing those different paths is crucial for avoiding injury during procedures involving the great vessels, the thyroid, or the esophagus in this region.
Okay. Now, let's revisit the phrenic nerves. We talked about the risk of blocking them during cervical plexus blocks. Let's trace their definite path through the root of the neck.
Right, so the phrenic nerves, formed from ventral rami of C3, C4, and C5, T3, 4, keeps the diaphragm alive, is the classic mnemonic.
Always useful.
They descend almost vertically down the neck. Their key landmark is that they run directly on the anterior surface of the anterior scalene muscle, deep to the prevertebral fascia, but superficial to the muscle itself.
So quite exposed on the front of that muscle.
Yes, relatively. As they reach the root of the neck, they continue downwards, passing between the subclavian artery, which is posterior to them, and the subclavian vein, which is anterior to them. They then enter the thorax, running down along the sides of the pericardium to reach the diaphragm.
And just to reiterate their function.
They are the sole motor supply to their respective hemodiaphragm. They also carry sensory information from the diaphragm's central part, the pericardium, and parts of the pleura. But the motor function is the most critical aspect here. Any injury or compression along this path, especially in the crowded root of the neck, directly impacts breathing.
Got it. Phrenic nerves. On the anterior scalene, between subclavian artery and vein, essential for breathing. Finally, in this neurovascular bundle, let's talk about the sympathetic trunks. These control fight or flight responses. What's happening with them in the root of the neck?
The sympathetic trunks are chains of ganglia that run vertically on either side of the vertebral column. In the neck, there are typically 3 cervical ganglia, superior, middle, and inferior. The one most relevant to the root of the neck is the inferior cervical ganglion.
Okay. And is there anything special about its location or connections?
Yes, there's something quite common and clinically significant. In about 80% of people, the inferior cervical ganglion fuses across the neck of the first rib with the first thoracic ganglion.
They merge together.
Exactly. This fused structure forms a larger ganglion called the cervicothoracic ganglion, more commonly known as the stellate ganglion because it sometimes has radiating nerve processes that give it a star-like shape.
Stellate ganglion, where exactly is it located? It sounds deep.
It is quite deep. It typically lies on or just anterior to the transverse process of the C7 vertebra, very close to the neck of the first rib. Crucially, it sits just posterior to the origin of the vertebral artery as it arises from the subclavian artery.
Okay, close to C7, the first rib, and the vertebral artery origin. Why is this stellate ganglion so important? What does it control?
It's a major relay station for sympathetic innervation. The postganglionic fibers originating here travel to supply structures in the head, neck, and importantly, the entire upper limb. This includes controlling blood vessel diameter, sweat glands, and the small muscles of the eye, like the dilator pupillae.
I see. So blocking this ganglion would affect sympathetic function in the arm and head. I think I've heard of stellate ganglion blocks being used therapeutically.
Yes, precisely. Stellate ganglion blocks involve injecting local anesthetic around the ganglion. This is sometimes done to treat conditions involving excessive sympathetic tone or sympathetically maintain pain in the upper limb, like certain types of complex regional pain syndrome, CRPS, or perhaps Raynaud's phenomenon. By temporarily blocking the sympathetic outflow, you can sometimes relieve pain and improve blood flow.
And conversely, if the ganglion is damaged, say by trauma or a tumor.
Damage to the stellate ganglion, or the sympathetic trunk pathway leading to it, can result in a very specific set of clinical signs known as Horner syndrome.
Horner syndrome. What does that look like?
It's characterized by a classic triad of symptoms on the same side as the lesion. First, meiosis, which is a constricted pupil because the dilator muscle is paralyzed. Second, pitosis, which is a droopy upper eyelid due to paralysis of a small smooth muscle in the eyelid. And third, anhidrosis, which is decreased or absent sweating on that side of the face and neck. Sometimes you also see flushing of the skin due to vasodilation.
Meiosis, ptosis, and hydrosis. A very distinct clinical picture pointing to sympathetic pathway disruption in the neck or upper thorax.
Exactly. Its location near the lung apex, vertebral artery, and brachial plexus roots means it can be affected by various pathologies in the root of the neck or superior mediastinum like Pancoast tumors of the lung. So recognizing Horner syndrome is key.
Okay, we've navigated the complex root of the neck. Now let's move superiorly and look at the structure the neck supports the head. Anatomically, how do we typically divide the skeleton of the head?
The cranial skeleton is generally divided into two main functional parts. There's the neurocranium, which is the bony box that encloses and protects the brain, its meningeal coverings and associated vessels. And then there's the viscerocranium, which forms the skeleton of the face, the orbits, nasal cavities, jaws.
Neurocranium for the brain, viscerocranium for the face. Is the proportion between these two constant throughout life?
No, not at all. It changes quite dramatically, actually. At birth, the neurocranium is huge relative to the viscerocranium. The brain and eyes develop early and rapidly, so the brain case dominates, making up maybe 7/8 of the total cranial volume. The facial skeleton is comparatively small and underdeveloped.
Right. Babies have proportionally large heads and small faces.
Exactly. Then, as a child grows, the facial skeleton undergoes significant development. The jaws enlarge, the permanent teeth erupt, the paranasal sinuses expand. This all contributes to the growth of the viscerocranium. By adulthood, the proportions have shifted, and the facial skeleton makes up roughly 1/3 of the total cranial size.
Interesting shift. Now, the cranium needs to be strong to protect the brain, but it also needs to withstand forces from things like chewing or even impacts. Is the bone thickness uniform everywhere?
No, it's definitely not uniform. The skull employs a clever structural strategy. It has areas of relatively thin bone, but these are reinforced by thickened regions called cranial buttresses.
Buttresses, like in architecture.
Precisely like that. These are pillars or arches of thicker bone that transmit forces from chewing or from a blow to the head around the weaker areas and towards the stronger parts of the cranial base or vault. They act like internal roll bars or reinforcing struts.
Can you give some examples of these buttresses?
Sure. A key vertical one is the front nasal buttress, connecting the forehead down through the medial side of the orbit to the upper jaw. Horizontally and laterally, you have the zygomatic arch connecting to the lateral orbital margin, which takes forces from the side of the face and transmits them backwards and upwards. These buttresses effectively dissipate stress across the cranial structure.
So, when the force of an impact overcomes the strength of the bone, even with these buttresses, we get a cranial fracture. Are there typical patterns of fracture clinicians look for?
Yes, the patterns often relate to the type and location of the impact. The most frequent type is a linear calvarial fracture. This is usually a simple crack or line fracture, often radiating away from the point of impact. While serious, the bone fragments don't typically get displaced inwards.
Okay, a linear crack. What's more dangerous?
Much more dangerous are depressed fractures. These usually result from a significant force applied to a small area, like being hit with a hammer or a hard object. Here, a fragment of the skull bone is actually pushed inward below the level of the surrounding cranium.
And the danger there is direct brain injury.
Exactly. The depressed fragment can directly compress, bruise, or even lacerate the underlying brain tissue and its coverings. This often requires immediate neurosurgical intervention to elevate the fragment and manage any underlying brain damage. The location matters too. Fractures across thin areas like the laterian, where several bones meet on the side of the head, are particularly dangerous because they can tear underlying arteries, like the middle meningeal artery, causing epidural hematomas.
Right. Okay. Moving from the bone to the soft tissues of the face, just looking at someone's face, there's standard surface landmarks we use to describe things, right?
Oh, absolutely. These are essential for physical examination and communication. For instance, the glabella, that smooth, slightly depressed area between the eyebrows. The superciliary arches, the bony ridges just deep to the eyebrows. The nasolabial sulcus, the groove running from the side of the nose down towards the corner of the mouth. And the philtrum, that vertical indentation in the midline of the upper lip, below the nose. The vermilion border of the lips is another key landmark.
Using these helps pinpoint locations accurately. Now, speaking of the area around the eyes, specifically those superciliary arches, why does getting hit there often result in such a spectacular black eye?
Ah, the classic black eye or periorbital ecchymosis. It happens because of a combination of factors related to the anatomy right there. First, the superciliary arch is a sharp, bony prominence. So a blow there easily cuts small blood vessels in the overlying skin and subcutaneous tissue.
Okay, so you get bleeding under the skin.
Right, extravasated blood. But the key thing is the nature of the surrounding tissue, especially in the eyelids. It's very loose areolar connective tissue with very little deep fascia to compartmentalize fluids.
So there's nothing to hold the blood and swelling in one place.
Exactly. Unlike, say, your arm, where fascia might contain a bruise to a specific area, around the eye, the extravasated blood and the associated inflammatory fluid are free to spread easily within this loose tissue. And because the tissue is so loose, it swells up dramatically.
And why does it often settle under the eye, even if the blow was to the eyebrow?
Gravity. The fluid tends to pool and track downwards into the upper and especially the lower eyelids, causing that characteristic puffiness and dark purplish discoloration. It's the combination of fragile vessels over sharp bone and loose, uncompartmentalized subcutaneous tissue that creates the perfect storm for a shiner.
Makes sense. Now, let's consider a couple of clinically important scenarios involving the lower face and jaw. First, dental anesthesia. How do dentists numb up the lower teeth effectively?
They typically use what's called an inferior alveolar nerve block. This targets the inferior alveolar nerve, which is a major branch of the mandibular division of the trigeminal nerve, CNV3.
Okay, and where do they aim the injection?
The target is the mandibular foramen. This is an opening on the medial or inner surface of the ramus of the mandible, the upright part of the lower jaw. The inferior alveolar nerve, along with its accompanying artery and vein, enters the mandible through this foramen to run within the mandibular canal, supplying the lower teeth.
So the injection is done inside the mouth, aiming for that spot on the inner side of the jawbone.
Correct. The dentist palpates landmarks inside the mouth to locate the approximate position of the foramen and injects the local anesthetic solution around the nerve just before it enters the canal.
And what's the effect of a successful block? What gets numb?
A successful inferior alveolar nerve block results in anesthesia numbness of all the mandibular teeth on that side, right up to the midline. But it also anesthetizes the lower lip and the skin of the chin on the same side.
Why the lip and chin?
Because before the nerve enters the teeth sockets, it gives off a branch called the mental nerve, which exits the mandible further forward through the mental foramen. The mental nerve supplies sensation to the lower lip and chin. So when a patient reports that their lip and chin feel numb, the dentist knows the block has successfully reached the main trunk of the inferior alveolar nerve.
Ah, the lip and chin numbness is the confirmation sign. Got it. Now, another structure in that general vicinity is the parotid gland, the large salivary gland over the angle of the jaw. Conditions like mumps cause it to swell up, and it's notoriously painful. Why is parotid swelling or parotiditis so painful?
The severe pain associated with parotid swelling, like in mumps, is primarily due to the toughness of the capsule surrounding the gland, the parotid sheath.
The sheath is the key.
Yes. This sheath is derived from the investing layer of the deep cervical fascia, and it's very strong, dense, and relatively inelastic. It doesn't stretch easily.
So when the gland inside swells up,
The tough sheath resists the expansion. This causes a significant buildup of pressure within the gland, compressing the sensitive glandular tissue against surrounding structures, particularly the mastoid process posteriorly. This internal pressure is what causes the intense pain.
like trying to inflate a balloon inside a tight box.
Exactly. And furthermore, the pain is often made worse by opening the mouth or chewing, because those movements compress or stretch the swollen gland further.
And sometimes the pain feels like it's in the ear or the jaw joint.
Yes, referred pain is common. The sensory nerve supply to the parotid gland and its sheath comes largely from the auriculotemporal nerve, which is another branch of CNV3. This same nerve also provides sensory innervation to the temporomandibular joint, PMJ, and parts of the external ear and scalp.
Ah, so because the same nerve serves the gland, the ear, and the TMJ, the brain interprets the intense signals from the swollen gland as also coming from those other areas.
Precisely. It's a classic example of referred pain based on shared sensory innervation pathways. The anatomical proximity and shared nerve supply explain why mumps pain often radiates to the ear and jaw.
Okay, moving to some highly specialized systems now. Let's focus on the eye, an incredible organ. Can you give us a quick overview of its basic structure, thinking about its layers?
Sure, the eyeball itself is roughly spherical and sits within the bony orbit. Structurally, you can think of it as having 3 concentric coats or layers.
3 layers. What's the outermost one?
The outermost is the fibrous layer. This provides structural support and protection. Posteriorly, it's the tough, white, opaque sclera, the white of the eye. Anteriorly, it becomes the transparent cornea, which is the clear window that light first passes through.
Okay, sclera and cornea form the outer shell. What's the middle layer?
The middle layer is the vascular layer, also called the uvea. As the name suggests, it's rich in blood vessels. Posteriorly, it consists of the choroid, which lies between the sclera and the retina and provides nourishment. Anteriorly, the vascular layer becomes specialized into 2 structures, the ciliary body and the iris.
Ciliary body and iris, what do they do?
The ciliary body contains the ciliary muscle, which controls the shape of the lens for focusing, accommodation, and the ciliary processes, which produce the aqueous humor fluid. The iris is the colored part of the eye. It acts like the diaphragm of a camera, controlling the size of the pupil to regulate the amount of light entering the eye.
Got it. Outer fibrous, middle vascular, and the innermost layer.
The innermost layer is the neural layer, which is the retina. This is the light-sensitive tissue containing the photoreceptor, cells, the rods and cones that convert light energy into electrical signals, which are then sent to the brain via the optic nerve.
So light comes through the cornea, passes through the pupil, controlled by the iris, then through the lens, focused by the ciliary body, crosses the main cavity of the eye, and finally hits the retina.
That's the path.
Yeah.
And to be precise, the light actually passes through 4 refractive media that bend the light rays to focus them onto the retina.
4 media. What are they?
First is the cornea itself. It does the most significant amount of light bending, acting as the eye's primary fixed lens. Second is the aqueous humor, the fluid filling the space between the cornea and the lens. Third is the lens, the adjustable focusing element. And fourth is the vitreous humor, the gel-like substance filling the large posterior cavity of the eye behind the lens.
Okay. Let's focus on that aqueous humor for a moment. You said it's produced by the ciliary processes. This fluid has to circulate and drain properly to maintain normal eye pressure, right?
Absolutely. Maintaining the correct intraocular pressure, IOP, is crucial for the health of the eye, and it depends entirely on the balance between the production and drainage of aqueous humor.
So, trace the fluid's path for us. Where is it made and where does it go?
It's continuously produced by the ciliary processes, which are part of the ciliary body located just behind the iris. This fluid fills the posterior chamber, which is the small space between the iris and the lens.
Okay, produced behind the iris, then what?
From the posterior chamber, the aqueous humor flows forward, passing through the pupil, the opening in the center of the iris, to enter the anterior chamber. This is the larger space between the cornea and the iris.
Right, so it fills the front part of the eye. How does it get out?
It drains out of the eye primarily through a specialized drainage structure located in the angle where the iris meets the cornea. This is called the trabecular meshwork. It's like a spongy filter system.
Okay, a meshwork filter in the angle.
Exactly. The aqueous humor percolates through this meshwork and then drains into a circular channel called the scleral venous sinus, also known as the canal of Schlemm, which eventually returns the fluid to the bloodstream.
So production in the posterior chamber, flow through the pupil to the anterior chamber, drainage via the trabecular meshwork into the canal of Schlemm. It's a constant flow.
A constant, delicate balance. The rate of production normally equals the rate of outflow, maintaining a stable IOP.
What happens if that balance is disrupted? Specifically, if the outflow is blocked?
If the drainage pathway, particularly the trabecular meshwork, becomes clogged or functions poorly, The aqueous humor can't drain out as fast as it's being produced.
So fluid builds up inside the eye.
Precisely. This causes the intraocular pressure to rise, sometimes dramatically. This condition is known as glaucoma.
And why is high IOP so damaging?
Because the increased pressure inside the eye compresses the delicate structures within it. The optic nerve head, where all the nerve fibers from the retina gather to leave the eye, is particularly vulnerable. Sustained high pressure damages these nerve fibers, leading to progressive loss of peripheral vision and, if untreated, eventual blindness. Understanding this aqueous humor dynamic is absolutely fundamental to diagnosing and managing glaucoma.
A crucial system to keep in balance. Okay, shifting back to the nervous system, let's talk about the major sensory nerve of the face, cranial nerve V, the trigeminal nerve. It's a big one.
It's huge, yes. CNV is primarily responsible for carrying general somatic sensation, touch, pain, temperature from almost the entire face, the scalp as far back as the vertex, the mucous membranes of the nasal cavity and oral cavity, including the teeth and gums, the cornea and conjunctiva of the eye, and even parts of the dura mater lining the inside of the skull.
Wow, extensive territory. And it does this via three main divisions, right?
Correct. It splits into three large branches. V1, the ophthalmic division, supplies the forehead, upper eyelid, cornea, and bridge of the nose. V2, the maxillary division, covers the midface, lower eyelid, cheek, upper lip, upper teeth, and nasal cavity. And V3, the mandibular division, handles sensation from the lower face, lower lip, chin, lower teeth, anterior two-thirds of the tongue, for general sensation, not taste, and also carries the motor fibers to the muscles of mastication.
V1, V2, V3, covering distinct facial zones. Now, this nerve is unfortunately associated with a particularly nasty pain condition.
Yes, trigeminal neuralgia, sometimes called tympanic douloureux. It's considered one of the most painful conditions known to medicine.
What characterizes it?
It's characterized by sudden, recurrent episodes of excruciating, stabbing, or electric shock-like pain. The pain is typically unilateral and follows the distribution of one or more branches of the trigeminal nerve, most commonly V2 or V3. The attacks can be triggered by seemingly innocuous stimuli, like light touch, chewing, talking, or even a breeze on the face.
What's thought to be the underlying cause?
The most common theory involves vascular compression. Often, an aberrant loop of an artery or vein is found compressing the trigeminal nerve root as it exits the brainstem. This compression is thought to cause demyelination loss of the nerve's insulating sheath, leading to hyperexcitability and the generation of these spontaneous pain signals. While other causes exist, this neurovascular conflict is the leading explanation. The severity really underscores the importance of this nerve's function.
Definitely. Let's revisit another major cranial nerve we met in the neck, the vagus nerve, CNX. We talked about its path, but let's expand on its functions beyond the neck. It has a huge regulatory role, doesn't it?
Oh, absolutely immense. The vagus is the main nerve of the parasympathetic nervous system for the chest and much of the abdomen. Its name means wanderer, which is very appropriate given its extensive distribution.
So what kind of motor functions does it have?
It provides somatic motor innervation to most of the voluntary muscles of the pharynx for swallowing and the larynx for voice production. It also supplies motor fibers to the upper part of the esophagus.
Okay, swallowing and speaking. What about its visceral motor functions, the parasympathetic stuff?
This is where its reach is truly vast. Its preganglionic parasympathetic fibers travel to ganglia located near or within the target organs. From there, postganglionic fibers regulate smooth muscle contraction and gland secretion in the thorax and abdomen. This includes slowing the heart rate, constricting the bronchioles in the lungs, stimulating peristalsis, muscle contractions, in the gastrointestinal tract, and promoting digestion.
How far down the digestive tract does its influence extend?
It controls the gut, all the way down to the splenic flexure, or left colic flexure, of the large intestine. So that covers the stomach, small intestine, ascending colon, and most of the transverse colon. Basically, the majority of the digestive process relies heavily on vagal input.
Incredible reach. So if the vagus nerve is damaged, say, unilaterally in the neck or chest, the consequences would be widespread.
They can be, yes, though often unilateral lesions might cause partial effects or be compensated for to some extent. However, we do see specific clinical signs.
We touched on this briefly before, but what are the classic, easily observable signs of a unilateral vagus nerve lesion, may be visible during an oral exam?
Two key signs relate to its innervation of the palate and larynx. First, the soft palate on the affected side will sag, because the levator veli palatini muscle, which elevates the palate, is paralyzed. When you ask the patient to say which normally causes symmetrical elevation of the palate, the uvula, the little structure hanging down in the middle, will deviate towards the normal, unparalyzed side.
Okay, palate sags, uvula points away from the lesion.
Correct. The healthy side pulls the uvula over. The second sign is hoarseness, or a breathy voice. This is because the vagus nerve, primarily via its recurrent laryngeal branch, innervates almost all the intrinsic muscles of the larynx, including those that control the tension and position of the vocal folds. Paralysis of a vocal fold results in dysphonia, or voice change.
So uvula deviation and hoarseness are strong indicators of a potential vagus nerve problem.
Very strong indicators, yes, especially if they occur together acutely.
Finally, let's just briefly touch on how vulnerable cranial nerves are to injuries at the base of the skull. Fractures there can have very specific neurological consequences, right?
Absolutely. The base of the skull is riddled with foramina openings through which the cranial nerves and major blood vessels pass. These foramina are points of potential weakness, and a fracture line running across one can easily shear or compress the nerve passing through it.
Can you give an example? Maybe involving the sense of smell.
Sure, cranial nerve A, the olfactory nerve, isn't a single nerve trunk, but rather a collection of fine filaments that pass from the nasal cavity up into the cranial cavity through the tiny holes of the cribriform plate of the ethmoid bone, right at the base of the anterior skull.
Okay, that sounds delicate.
It is. A fracture involving the cribriform plate, perhaps from a blow to the front of the head or face, can easily sever these delicate olfactory filaments.
And the result?
Two potentially serious consequences. First, anosmia, the complete loss of the sense of smell. Since much of what we perceive as flavor is actually smell, this can significantly impact quality of life. Second, and more immediately dangerous, is the risk of cerebrospinal fluid, CSF rhinorrhea.
CSF leaking out the nose.
Yes, the fracture tears not only the nerve filaments but also the meninges, the membrane surrounding the brain. This creates a direct communication between the subarachnoid space, which contains CSF, and the nasal cavity. CSF leaking out the nose is a clear sign of a skull-base fracture.
And the danger there isn't just fluid loss, is it?
The major danger is infection. That opening provides a pathway for bacteria from the nasal cavity to ascend directly into the cranial cavity, potentially causing meningitis or a brain abscess, which can be life-threatening. So CSF rhinorrhea is a neurosurgical emergency.
Wow. Okay, one more example, the facial nerve, CN. It has a long, complicated path. Where is it particularly vulnerable?
CN7 takes a very tortuous course through the temporal bone and then exits the skull via the stylomastoid foramen, located just behind the ear. After exiting, it immediately enters the substance of the parotid gland, where it branches out extensively to supply all the muscles of facial expression.
So injury in the parotid region is a problem.
A major problem. Lacerations to the face that involve the parotid gland, or even surgery on the gland itself, carry a high risk of damaging the facial nerve or its branches. It's actually considered the most frequently paralyzed cranial nerve due to trauma or iatrogenic injury.
And what does that paralysis look like? Bell's palsy is related to this, right?
Bell's palsy is an idiopathic inflammation of the nerve, but the resulting paralysis is the same as from trauma. With the complete lesion of CN7 after it exits the stylomastoid foramen, you get paralysis of all the facial muscles on that same side, ipsilateral.
What are the specific signs?
The patient cannot wrinkle their forehead on that side. They can't close their eye completely. The orbicularis oculi muscle is paralyzed, leading to the eye remaining open and potentially drying out. The corner of the mouth droops, and they can't smile or bare their teeth symmetrically. Food might collect in the cheek because the buccinator muscle is weak. It's a very characteristic and functionally devastating picture.
Eye stays open, mouth droops, no forehead wrinkles. Very clear signs.
Yes. These examples really drive home how closely linked the cranial nerves are to the bony structures they pass through or near, and how focal damage can lead to very specific and profound functional deficits. Anatomy truly dictates pathology here. #TACF outro.
Well, that was certainly an intensive journey. We started deep within the neck, looking at those crucial fascial compartments, moved outwards to the defining muscles like the SCM, navigated the incredibly crowded root of the neck, and then bridged up into the head, covering the skull, face, eye, and some major cranial nerves.
Yeah, we really covered a lot of ground. From understanding how fascia channels infection, remember the visceral pretracheal fascia leading to the mediastinum, to mapping the posterior triangle and the vulnerability of CNXI. Then we delved into that neurovascular bundle at the thoracic inlet, the subclavian branches, the differing paths of the vagus nerves, the critical phrenic nerve on the anterior scaling.
And then connecting it upwards, thinking about the skull's buttresses for strength, the reason for a black eye, the mechanics of the inferior alveolar nerve block, and why mumps hurt so much due to the parotid sheath.
Right. Plus the delicate balance of aqueous humor in the eye, the territory of the trigeminal nerve and the pain of neuralgia, and the widespread impact of vagus nerve function and lesions. And finally, how skull-base fractures directly threaten specific cranial nerves like olfactory and facial. It all highlights those intimate anatomical
It
relationships.
really does. The proximity of structures, the pathways they create, it dictates so much of clinical practice.
And, speaking of those cranial nerves, we've touched on several of them today, V7X, X, XA, and mentioned others like I. Given how absolutely central they are to neurology and head and neck anatomy,
You think they deserve their own dedicated session?
I think for our final deep dive in this series, it would be perfect. We should consolidate everything, go through all 12 cranial nerves, systematically their origins, pathways, functions, sensory, motor, autonomic, and the key clinical signs associated with lesions of each one. A comprehensive, high-yield review to tie it all together.
That sounds like an essential wrap-up. Okay, let's plan on that. Full cranial nerve review for our next and final session in this anatomy series.
Excellent.
So that brings episode 38 of Bookfulness to a close. Thanks so much for joining us on this detailed exploration of the neck and connected head anatomy.
Thanks for listening to Bookfulness.